Leila Lagandaon, the Health Education Manager here at AiArthritis, and I am reporting back from ACR 2023 as a part of our Go With Us to Conference program. And I will be discussing part 2 of the session, RA treatment, Are We Good Enough? And I decided to make a second video because I think the other video that I made was long enough. So I wanted to split this into a second one. These two topics that they had for the two talks, I really could think they could have been like 30-minute sessions or 45-minute sessions themselves instead of a 20-minute talk. So I wanted to get into it and just give an overview. The first talk was a little bit more about like the evolution of treatment and guidelines for RA throughout time and where they're headed to now. And this session is this talk is more specifically having to do with like tapering and treating to target and what to taper and when to taper and who to taper for, since tapering is a really big topic when it comes to these medications. So I am also going to share the PowerPoint for this one. Thank you again to all the speakers that have shared their PowerPoints with us. It really helps us to help disseminate the information to you. So yeah, let's get into it. Alrighty, so this talk is called In Whom Should We Taper csDMARDs or Advanced Therapies in RA? Should we attain drug-free remission? And I think that a lot of people may have that as a goal, or a lot of people may start out their disease journey wanting that to treat their RA without any drugs. It's a very tough topic to talk about because some people have their views. I do think that sometimes it is very hard to be able to have drug-free remission. So he talks about that more in here. And I think the really cool thing about this too is that this doctor talks about the difference between tapering strategies in both Europe and in the United States. So this is like an overview of what he talked about. Again, at the bottom, he says it's impossible to do this topic justice just in 20 minutes. So we're going to go through it. He has very like succinct slides, so we can just get into it. Why do we want to taper at all for these DMARDs? It's saving costs, for safety, cytokine expression levels, patient experience, and it's good strategy for medicine. And reasons to not taper if there's a flare. It will allow systemic disease with comorbidities to emerge. So sometimes when you are on a medication, it is suppressing your disease from progressing anymore. So if you do taper, there's the risk of the disease progressing and continuing on to comorbidities, and possibility to be unable to regain remission after that. There has also been successful reintroduction of remission in virtually all flares through the other things. Okay. So it's very difficult to refute the logic with tapering, specifically just with the patient's safety, with how the medications can deteriorate the body over time. So which drug is there more tapering with, or which one is better to taper, the DMARDs or methotrexate? So he said that they taper down more of the DMARDs in Europe, and in the USA they taper down methotrexate more. So the original approach, if the patient was in remission for 6 months, to stop the DMARDs, and that was largely unsuccessful because patients without that medication just ended up tanking and their symptoms going way out of control. There has been a lot of studies on DMARD tapering, and the problems that come about are in late disease. Most studies produced self-evident predictors and predictable results, more flares in the tapering arm and little practical value. So there were extra flares when starting to decrease the medication. It really did have a lot of, there were a lot of remission induction studies that came from this research, and remission induction is not a standard practice, but does show what is possible. And despite the increasingly favored for poor prognosis patients. Okay, stopping all therapy and drug-free remission. as it's proven to be an unrealistic ambition, but can be achieved about maybe for 10 to 20%, mainly for seronegative or for milder patients. And it's more self-limiting versus like drug-induced homeostasis. And the trial data has not yet answered this question. We're still seeing how achievable this actually is. Tapering DMARDs focus on early remission, concerns about overtreatment being addressed. There are some questions about, is it really necessary for these patients to have these medications every single month at a certain point where they are doing well with their disease? One of the biggest things to deal with heterogeneity, or for each patient's situation being unique, is definitely finding biomarkers and imaging and immunology. And they may allow the selection of individuals rather than populations for more successful tapering and more suitable approach in late disease. And I think that's what's hard about these diseases, is that everybody is different and everybody has a preference of what they'd like to do versus not. And so it's trying to study a population in a clinical trial doing these things may be very difficult to find a big enough population that is the same because of how different everybody's diseases are. Okay, the predictors of successful tapering after remission induction: early treatment, speed of achievement of remission, absence of damage, good function, good quality of life, younger age, and low baseline DAS. So these are the people that they're looking for to try the tapering on in order to see how successful it might be. This talks a little bit about predicting a flare and the use of Doppler or ultrasounds and T cell subsets, which is really cool that they're starting to look at that and how that can help with the research on tapering. Alrighty, and summary: DMARD tapering in late disease. Flaring on tapering of DMARDs was associated with lower TREGs and elevated inflammation biomarkers. So definitely increasing the inflammation when tapering off the DMARDs. Tapering low-risk patients produces a rate of flare less than overall population continuing therapy and at no risk of not regaining remission. So encourage tapering if desired, and that is still a personal preference. For high-risk patients, tapering is not encouraged. High risk identifies both risk of flare and risk of not regaining remission. And in practice, could just check T cell subsets in those with normal CRP to identify low risk. And those are very simple blood tests that can be done. And flaring on continued DMARDs was associated with raised pain parameters and inflammation, and should be highlighted close to follow-up increased therapy research question. So that basically means that there's increased pain when flaring on these medications, and how to basically control that. Finally, the overall lessons of this was remission induction provides best chance of successful tapering in patients who are most willing to taper. Remission in early disease, either with DMARDs or with methotrexate, there is tapering possible. Before stopping DMARDs, taper first and wait and see how the patient reacts before attempting to completely get rid of it. Remission in late disease, tapering methotrexate is the better option. Tapering the DMARDs in unselected patients with a high flare rate, and flares reduced by tapering. And in the US, physicians correctly prefer methotrexate tapering in late disease. In Europe, physicians should restrict DMARD tapering to early remission and selected individuals in late disease, and need to refocus on methotrexate tapering as cost issues are diminishing and patient preference. And then important to identify risk for both flare and risk of not regaining remission. I think that's really big, is if there is any risk of me not regaining remission again after tapering down off of these medications, for a lot of people, it's definitely not worth the risk. especially if you have been on these medications for so long and you've been in a really good state. Changing things can be really scary for those patients. And again, hopefully we will be able to start to predict flares for the DMARD induced remission, and that will be really cool to see coming up in the future. Alrighty, that's it. I hope that you learned a little bit more about these different treatment opinions that these different rheumatologists have. I think it's very interesting to at least have more information about your options to bring up to your rheumatologist in the future, and maybe just even bring it up to have a conversation. I watched this video from AiArthritis talking about possibly, if I'm in a good disease state, that it might be beneficial for me to start tapering off of methotrexate. See what your rheumatologist has to say. And yeah, it really does help to get involved to that level with your treatment so you really fully understand what's going on. Alrighty, I hope you all have a great day, and I will talk to you all later.